Hi, I'm Dr. Keith Rose, an intensivist here at St. Luke's Roosevelt Hospital. Today we'll be reviewing proper central line placement. We will begin with the steps required to set up for a central line. We'll then take you through the full sterile technique, and then we'll actually go through all the steps involved in placing the catheter itself. We will be demonstrating the placement of a right-sided internal jugular catheter. This is our preferred site. However, the steps are the same if I'm placing a subclavian line or a femoral line as well. Femoral lines are generally a site to be avoided. Before beginning the procedure, one must go to Forms on Demand. Here you can access the central line bundle. Within the bundle, there is a safety checklist as well as the procedure note which can be downloaded. The safety checklist is very important. It must be completed by the nurse during the procedure. At the end of the procedure, the physician must sign it. It's important to assess the need for a central line daily. If a central line is no longer needed, it must be removed. Also, if a catheter is placed in the femoral site, given the risks of infection as well as DVT, one must document the need for this site to be utilized. This can be done on the safety checklist. Before starting any procedure, a timeout must be performed. This is a verbal agreement stated out loud between the nurse and the physician. The timeout must verify the 3 P's. First, we must verify that this is the correct patient. Second, we must verify that it's the correct placement, including the right or left side. Third, we must verify that this is the correct procedure to be performed on the patient. Allergies and consent should also be verified. Although we will be using ultrasound to guide the placement of our central line today, it's important to first examine the patient and identify our anatomical landmarks. I will start by exposing the area and making sure I have good access to the targeted area of interest. I will then identify the clavicle bone, and then, based on this, I can find the 2 heads of the sternocleidomastoid, and as they run superiorly, they form a triangle. The top of this triangle is a carotid artery, and just lateral to this is the internal jugular vein. We will now use ultrasound to survey up and down the patient's neck to find a safe location for central line placement. There are many different ultrasound machines available for use. You must orient yourself to the machine you are using. You must also orient yourself to the image you are obtaining. First off, on the probe, there is a marker on one side. There's a little notch here on this side of the probe. This assumes that the green dot here is on the upper left-hand corner of my screen. If I keep this probe on my left side, when I image the patient's neck, whatever's on the left side of the probe will show up on the left side of my screen, and on the right side of the probe, on the right side of my screen. This will help keep you oriented during the procedure. As I begin to survey the neck with the ultrasound probe, I will place a little cold gel onto the patient's neck. I will then identify 2 vascular structures. First, you will see a large compressible vein located laterally to the artery. The artery, you will note, is pulsatile and non-compressible. It's important to find a spot on the patient's neck where the vein does not lie directly over the artery. This would be a suitable location. You may need to adjust the depth on the ultrasound machine. You would do this to obtain the target vessel in the center of your screen. Once you find the appropriate depth, you can see it says 2.6 centimeters here. Each dot going down is about a half a centimeter. This will help guide you and let you know how deep you must go with your needle to access the vessel. You may also want to adjust your gain, which is how bright or how dull the image is. Doing this ensures proper resolution and getting the best image possible, keeping the procedure safe. When choosing an insertion site, it's important to survey up and down the neck. Higher up towards the apex of the triangle, the vein tends to be somewhat smaller. However, there's much less risk of a pneumothorax. Lower down in the neck, the vein tends to be bigger, but you are closer to the apex of the lung, making the pneumothorax risk somewhat higher. We will now begin to gather our supplies for the sterile field as well as the procedure itself. It's important to utilize the bedside table and to bring it close to the patient. You may also use the procedure cart, which contains all the necessary supplies. Some procedure carts may have a tray that can be extended, for which you can put some of your supplies here as well. I will begin by going through the procedure cart and obtaining all of my necessary supplies. On the bedside table, you will need to gather your central venous catheter kit, a sterile drape, a cap and mask for both you and the assistant. You need a sterile gown, 2 pairs of sterile gloves, some saline flushes, chloropreps, the ultrasound probe cover, 1 or 2 10 milliliter sterile syringes, and a sterile dressing for after the procedure. We will now begin to prepare our sterile field. The first step in this process is to put on a hat and mask. Anyone in the room needs to wear a hat and mask. If they're not doing it, you must remind them to do so. Hat and mask. We must now wash our hands. If my assistant does not remember to do so, I again must remind him. There are 2 ways to wash your hands. You can use soap and water. It's important to use enough soap and to get a good friction rub for at least 20 to 30 seconds. Alternatively, you can use the alcohol-based soaps, such as this Purell. It's important to remove all jewelry or watches and to get a nice, good area up to your wrists. Once my hands are washed, although this is not a sterile scrub, I must consider them sterile, and I must not touch anything that is not sterile. My assistant, however, although he's washed his hands, he's needed to open up the supplies for me. I will now ask my assistant to open up a pair of sterile gloves. I'll ask him to open them up, touching only the outside aspects of the paper, and to lay it flat open on the table so that I may put them on in a sterile fashion. I will first, with my right hand, pick up my left glove, allowing an opening for my hand to go in. Stepping away from the table, so as not to contaminate myself, I can put my hand into the glove, leaving over this fold in place. I will then use my left hand with 2 fingers. In this flap here, I will open up the glove, again, allowing an opening for my hand. My right hand can then go into the opening, and I can pull the glove up over my hand. I may then come back to this left glove and grab this fold and extend it up over my wrist. I now have a pair of sterile gloves on, and I will now use the chlorhexidine to clean the patient. I will now ask my assistant to open up the chlorhexidine swab so that I may begin to prepare the patient. It's important to have a large area exposed on the patient so that we may clean it properly. It's also important, if there are any tubes and lines in the way, to ensure before this that they're safely removed out of the sterile field. I will then begin using the chlorhexidine scrub and cleaning a very large area around this IJ. I will cover an area up to the patient's mandible, high up here along the apex of that triangle, and down to the patient's shoulder below the clavicle. I will do this for at least 1 minute. It's okay to go over the same area twice, but you do want to make sure it's scrubbed clean. I can flip this over and again scrub using the other side. Now that the area has been prepped, I may remove my sterile gloves. It's important to note that if I touch anything non-sterile here, I must again rewash my hands. If I'm able to not touch anything that's not sterile, I can then proceed with placing my gown. I'll ask my assistant in a sterile fashion to open up the sterile gown. Removing it from the package, we'll then open it up, exposing the gown. It's important to touch below only the yellow stripes. All right. I can then put my right hand in this little handle and the left hand here as well and allow the gown to fall. It's important to make sure you're clear of any obstacles to potentially contaminate your gown. I now insert my hands into the gown, careful not to raise my hands high above my head or low below my waist. Again, keeping my hands within my sleeves. I will now ask my assistant to tie my gown. This must be done in 3 places. First, he will tie up by my neck. Second, he will tie at my waist in the back. The third tie will come after my gloves are placed when I do the spin move. I will now ask my assistant to open up another pair of gloves in the same fashion as he did the first time, touching one of the outside aspects of the paper and opening the gloves flat on the table. In this step, careful not to stand too close to the table and contaminate my gown. I will, keeping my hands inside the sleeves, I will pick up the top part of the glove, exposing a hole to put my hand into. My hand will then come into the glove, and I will pull the glove up over my wrist. My left hand will now, using 2 fingers, make another opening for my right hand to come into. I will then take my right sleeve, insert it into the right glove, and pulling it up over, I will cover my sleeve. It's important not to have any of the white area of the sleeve exposed. The glove must cover this area in its entirety. I will now do the spin move. With 2 hands, I can grab the card with my right hand and the string with my left and pull that out. I will now hand the card to my assistant. He is to touch only the blue part of the card, and I will spin in a counterclockwise fashion. When I've come around, I will pull the string off of the card. My assistant may then dispose of the card, and I will tie the string to secure the gown. My gown and my gloves are now complete. I will now ask my assistant to open up the sterile drape to cover the patient. In a sterile fashion, I can open up the drape, and I must orient it. As you see on the drape, there's a picture of a patient. This implies that this is the top of the drape, which goes towards the head, and this is the foot of the drape, which goes towards the foot of the bed. Also, when I open it up, you will see that it says head here in the middle of the drape. This implies that this would be for left-sided catheters, and this will be for right-sided catheters. Today, as we're doing a right internal jugular, we will be removing only this cover hole. Now, this hole needs to be placed firmly over the patient. It may help to roll the gown in order to keep your hands away from the patient so you don't contaminate your gloves. In this case, I will find the area I want to place the drape, and again, I'll put it down and gently adhere it to the patient. Upon opening, it's important to not contaminate yourself and to open it high and then to let it fall out wide. Again, lifting it up and out and fall. I will now ask my assistant for help. Touching just the tip of the drape, we can extend the top part up over the patient. And again, using the bottom part of the drape, we can extend, lifting up and out so we don't contaminate the drape towards the lower half of the bed. I can now remove this cover and ensure that my drape is placed in proper position. Once the drape is placed, it should not be moved. If the drape is placed wrong, in the wrong position, it should be removed and a new drape applied. We will now prepare a sterile field over our bedside table. This can best be done with a half drape. Asking my assistant to open up a half drape, I can then lay it over the table and creating a nice large field for which to put my supplies on. I will now ask my assistant to open up a central venous catheter kit so that I may open it up, inspect its contents, and get ready for use. I will first open the kit. Within the kit you will find a syringe to attach our needles. You will find two needles. There's a large needle and there's also a shorter needle. For most internal jugular veins, the shorter needle is more than adequate. However, in this kit the larger needle is echogenic and can be seen better on ultrasound. So for demonstration purposes today, we will be using the longer needle. In the kit, I also will be able to inspect my catheter. Now removing these blue caps, and I will attach the enclosed HEP-lock caps. I will put them on the blue port as well as the white port. I will be leaving the brown port open, as this is the port that the wire must come out of. I will also ready my guide wire. I will remove the cap and I will inspect the wire and straighten out the J-loop by pulling the wire gently back. This will make it ready for use. I must now prepare my saline flush. This can be done in one of two ways. The first way, I'll ask my assistant to open up a 10 cc luer lock syringe as well as a blunt tip red needle. Attaching the needle to the syringe, I will ask my assistant to open up a small vial of saline, rubbing the top with alcohol, and then holding it up away from the field, but in a fashion that I can draw the saline out sterilely. I now have a 10 cc flush at the ready. Alternatively, I can ask my assistant to open up a 10 cc syringe of saline. This is a pre-filled syringe with sterile saline. It's important to note that the syringe itself is not sterile, only the saline inside it. I'll ask my assistant to gently and carefully, so as not to contaminate the field, inject the sterile saline into the hub. I may now take that same 10 cc syringe that I had and withdraw the saline for the flush. I will attach the saline-filled syringe to each of the three hubs and flush all three ports. I will now ask my assistant to open up the rest of the supplies and put them on my sterile field. This will include the sterile probe cover for the ultrasound probe, as well as my sterile dressing, and some extra gauze if needed. We will now also prepare the lidocaine to properly anesthetize the area prior to insertion of the catheter. Within your kit, you will find a 3 cc syringe for the lidocaine. You'll have a small vial of lidocaine, which needs to be opened safely using gauze to break open the top. You may then draw up the lidocaine into your 3 cc syringe. It is best to first use the 25 gauge needle to anesthetize the skin. This can also be done under direct ultrasound guidance. I will now bring this bedside table next to the patient's bed, and I will get the probe cover prepared and placed over the ultrasound probe. It must be opened carefully, not to lose the 2 rubber bands that are inside, as these are an important part of proper sterile placement. As I open the probe cover, you'll see there's 2 ends. There's an open end and there's a closed end. find it easiest to put my hand through the open end, and then the probe will rest gently into the closed end. I'll first open up some of the sterile ultrasound gel. Again, putting my hand through the open end, creating a pocket. I will inject a small amount, no more than half of the ultrasound gel in the packet, into this probe cover. It's important that this gel sits on top of the probe, as it is needed to transmit the signal. I will then ask my assistant to carefully place the probe into that same pocket, and I can then extend the sheath over the wire. Again, ensuring that there is gel over the probe cover, I will take my first rubber band and I'll place it directly over the probe head. My second rubber band will be placed also over the probe, but extended down the length of the wire to achieve a larger sterile covering. I will then leave my probe here at the ready. At this point, I will move to be standing behind the patient to complete the rest of the procedure. I will now again use the ultrasound to evaluate the patient's neck for central venous cannulation. At this point in time, it's also a good idea to place the patient in a Trendelenburg position. I will now put a small bit of gel onto the tip of my probe again. Again, orienting myself with the probe notch here on the left side. Therefore, the left of the screen will be the anatomical left. I can now examine the area that I find best for cannulation. I will again first identify the internal jugular vein, which is compressible easily, and the carotid artery medial to that, which I'm unable to compress. This is the area that I will cannulize. I will again take my lidocaine needle. At this point, inject lidocaine superficially at the area that I intend to puncture. However, as this is a mannequin, we will not be using lidocaine today. I will now prepare my needle for use. I will take my syringe, and again we're using the long needle today. I will line the bevel up with the needle, the bevel of the needle up with the numbers on the syringe to ensure that if the needle turns, I will know where my bevel is at all times. And there are two techniques to use ultrasound to cannulate this vessel. First is the triangulation method. In this method, I will locate the vein on the ultrasound, keeping it in the center of my screen. I will then take my needle in a triangulation fashion about 1 to 2 centimeters behind the probe, and a 45-degree angle. My needle will go into the patient's neck, and as it is advanced, will meet the vessel underneath the probe. Confirmation that I have done this is that I will see blood in my syringe. In this case, it is blue fluid, as it is a mannequin, confirming that I have cannulated the internal jugular vein. The disadvantage of this method is that I cannot see my needle track the course towards the vein. The second method is called the spear method. This method has the advantage of being able to visualize on ultrasound the needle as it traverses its course towards the vessel. Again, I will get the vein in view, and I will take the needle, and at a near perpendicular angle, I will begin entering the skin. Here, keeping the vessel in the center of my screen, I can see my needle traversing its course towards the vessel. It's important to always be pulling back on the plunger of the needle as you advance it. This way, as soon as you enter the vessel, you will get blood in the syringe and you will know that you are in the vessel. Again, I've gotten blue fluid, confirming my location. At this point, I will put the ultrasound down and I will firmly grab the needle so as not to allow any movement. At this point, I will take the syringe off of the needle and I'll grab my guide wire. My guide wire, I'll begin to insert it into the needle. There are markers on the guide wire telling me how far the guide wire is in. As you can see here, there are 2 hash marks denoting 20 centimeters. The guide wire does not need to be advanced any further than 20 centimeters. I can now, that the guide wire is in the vessel, remove the needle. At this point, prior to dilation, it is important to confirm that the wire is in the proper vessel. This can again be done with ultrasound. You can see the wire in the vessel. However, it's better seen in a transverse fashion by turning the probe in the longitudinal section. You can again see the vein, which is collapsible, and you can see the wire right in the middle of the vein. I will now take my blade and make a small incision at the entry point. This can best be done by holding the blade facing forward and with a gentle downward motion, careful not to cut the wire, inserting the blade about halfway in just to make a small nick in the skin. The blade can then be retracted to avoid injury. I will now take my dilator. The dilator can be advanced over the wire. Careful never to ever let go of the wire. The dilator can be inserted best by holding the distal end of the dilator and advancing in a twisting-like motion about 1 to 1.5 inches, or about the distance it is to get to the vein based on your ultrasound measurements. The dilator can then be removed and placed at the side. Gauze may need to be kept over it, as there may be some oozing during this step. I will now take my central venous catheter and I will place the catheter over the wire. Again, careful to never let go of the wire. I will pull the wire back until it comes out the distal end of the brown port. I may then gently advance the catheter over the wire into the internal jugular vein. Catheter can be inserted to about 15 or 16 centimeters for the right IJ, and the wire can be removed. If you are doing a left IJ procedure, you may need an additional 2 or 3 centimeters. The line can then be flushed and then sutured in place. I'll first take my last hep lock and attach it to the brown port. At this point, I will flush all 3 catheters. The syringe can be attached to the end. With gentle suction, you will see the blood come up into the tubing, and then you can then flush it back in. You must do this for all 3 ports. The line must now be secured in place. At the entry point, you can use the white hub and you put it over the catheter. You would then take the blue hub and you will put it over the white hub. You'll hear a snapping and you'll know that the catheter secure device is in place. We'll now then suture both these 2 areas as well as these 2 areas. As this is a mannequin, we will not be suturing today. We must now place on our sterile dressing. In order to do this, we must pull back the patient cover to expose the area to attach the dressing. Careful not to contaminate the fields or my hands, I will gently lift up the drape and pull it back over the patient. I will take the dressing, keeping the center of the dressing right over the insertion point. The dressing can be gently applied and will adhere to the skin. And then remove the applicator. The dressing is now in place. Now the patient can be taken out of the Trendelenburg position. We must clean up our area and dispose of any sharps. We must also order a chest x-ray. We will also complete the safety checklist as well as a procedure note. And again, we must assess the need for the central line on a daily basis. When it is no longer needed, the line should be removed. Also, for patients in the ICU, there is a maintenance bundle. This can be found on the patient's flow sheet. This must be completed on a daily basis. Thank you very much, and good luck in placing central venous catheters.